Question 1. Radiation treatment planning. A radiation oncologist is planning an intensity modulated radiation therapy IMT treatment for a patient with a head and neck tumor. The goal is to deliver a highly conformal dose to the gross tumor volume (GTV) while minimizing exposure to the organs at risk cause, such as the spinal cord and parotid glands. During optimization, the planner notices that the dose gradient between the target volume (PTV) and surrounding tissues is not as steep as expected, leading to unnecessary irradiation of the ores. What is the best approach to improve dose conformity while maintaining adequate tumor coverage? A. Increase the number of beam angles to allow better modulation of the dose distribution. B. Reduce the prescribed dose to the PTV to decrease overall radiation exposure. C. Use a larger margin for the PTV to ensure tumor coverage. D. Disable dose constraints for the ores to allow the optimizer to focus solely on tumor coverage. Answer. A. Increase the number of beam angles to allow better modulation of the dose distribution. Explanation. Increasing the number of beam angles allows for better modulation of the dose, improving the ability to shape the radiation dose around critical structures while ensuring adequate tumor coverage. IMT relies on multiple beam directions to achieve highly conformal dose distributions, and increasing beam angles enhances the optimizer's ability to distribute dose effectively. Incorrect choices. B. Reducing the prescribed dose to the PTV compromises tumor control and is not recommended strategy. The dose should be determined based on clinical guidelines and tumor characteristics. C. Using larger margin for the PTV increases radiation exposure to nearby critical structures, potentially leading to higher toxicity. Proper margins should be determined based on imaging. Motion studies. D. Disabling dose constraints for the ores is poor strategy, as it would result in unacceptable toxicity. Proper balance between tumor coverage and organ sparing is essential in IMT planning. Guidelines reference. American Association of Physicists in Medicine (OPM) Task Group 119 and 120 reports on IMT quality assurance and planning strategies. ICRU Report 83, International Commission on Radiation Units and Measurements on Prescribing, Recording, and Reporting Photon Beam Therapy. Question 2, Scenario-Based. Quality Assurance and Safety in Radiation Therapy. Dr. Tanaka, a medical physicist, is performing a routine quality assurance (CAR) check on a linear accelerator (LINAC) used for external beam radiation therapy. During the output verification test, she notices that the measured dose is 3% lower than the expected dose based on the machine's calibration records. The LINAC was last calibrated 2 weeks ago, and there have been no reported mechanical failures. What should Dr. Tanaka do in this situation? A. Continue using the machine, as a 3% variation is within an acceptable daily fluctuation range. B. Recalibrate the machine immediately and document the findings in the CAR log. C. Report the discrepancy and perform additional checks to identify potential causes before deciding on recalibration. D. Ignore the deviation, as patient-specific care will account for any minor dose variations. Answer. C. Report the discrepancy and perform additional checks to identify potential causes before deciding on recalibration. Explanation. A 3% deviation in dose output is concerning and requires further investigation before recalibration. The first step should be to report the discrepancy and conduct additional checks to identify potential causes such as temperature or pressure variations, chamber instability, or software errors. Discrepancy persists. Recalibration may be necessary. Incorrect choices. A. Assuming the 3% variation is acceptable is incorrect, because while daily fluctuations within 2% are generally acceptable, a persistent 3% deviation could indicate a more significant underlying issue. B. Immediately recalibrating the machine without identifying the root cause may overlook other potential issues that need to be addressed. D. Ignore. Deviation is unsafe, as small deviations can accumulate and impact patient treatment over time. Guidelines reference. OPM Task Group 142 Report on Quality Assurance of Medical Accelerators. International Atomic Energy Agency (IA) Guidelines on Radiation Therapy Machine Calibration and CAR. Question 3. Radiobiology. A researcher is studying the effects of fractionation schedules on tumor response and normal tissue toxicity. One of the key factors influencing this response is the concept of the linear quadratic (LQ) model, which describes cell survival in relation to dose per fraction. Which of the following statements best describes how the AB ratio impacts treatment planning? A. Tumors with low AB ratio are more sensitive to changes in fractionation schedules, making them more responsive to hyperfractionation. B. Tumors with higher BAB ratio are more sensitive to changes in fractionation schedules, making them more responsive to hyperfractionation. C. The AB ratio is only relevant for normal tissue effects and does not influence tumor control. D. Hyperfractionation is equally effective for all regardless of their AB ratio. Answer: 8 tumors with a low AB ratio are more sensitive to changes in fractionation schedules, making them more responsive to hypofractionation. Explanation: the AB ratio is a critical concept in radiobiology that describes the response of tissues to fractionated radiation. Tumors and tissues with low AB ratio, e.g., prostate cancer, some sarcomas, are more sensitive to changes in fractionation schedules, meaning they benefit more from hypofractionation, fewer fractions with higher doses per fraction. This is because such tissues repair sublethal damage more efficiently, making them respond similarly to fewer high-dose fractions as they would to conventional fractionation. Incorrect choices. B. Tumors with high AB ratio are more responsive to hypofractionation is incorrect because higher B tumors, e.g., most rapidly dividing cancers, respond well to conventional fraction rather than hypofractionation. C. The AB ratio only applies to normal tissues is incorrect. While the ratio is crucial for normal tissue sparing, it also significantly impacts tumor response. D. Hypofractionation being equally effective for all tumors is incorrect since different tumors have varying AB ratios, requiring different fractionation approaches. Guidelines reference: the linear quadratic model and its application in radiotherapy. ICRU Report 50 and 62. American Society for Radiation Oncology, Guidelines on Hypofractionation for Prostate and Breast Cancer. Question 4. Radiation dosimetry and measurement techniques. Accurate dose measurement is critical in radiation therapy to ensure the prescribed dose is delivered to the patient while minimizing harm to healthy tissues. One of the primary tools used in dosimetry is the ionization chamber. However, other methods, such as thermoluminescent dosimeters (TLDS) and film dosimetry, are also employed in different clinical scenarios. Which of the following statements is most accurate regarding radiation dosimetry and measurement techniques? Ionization chambers are the gold standard for absolute dose measurement due to their stability and accuracy, but are not suitable for high spatial resolution measurements. B. Thermoluminescent dosimeters (TLDS) provide real-time dose measurements, making them ideal for in vivo dosimetry. C. Radiochromic film dosimetry is primarily used for in vivo patient dose verification and is not suitable for small field dosimetry. D. Diode detectors are preferred over ionization chambers for absolute dose calibration because they have superior energy independence. Answer: ionization chambers are the gold standard for absolute dose measurement due to their stability and accuracy, but are not suitable for high spatial resolution measurements. Explanation: Option O is correct because ionization chambers are widely used in dosimetry due to their high accuracy, stability, and reproducibility. However, their relatively large size makes them unsuitable for measuring highly localized dose distributions, such as those found in stereotactic treatments. Option B is incorrect because TLDS do not provide real-time dose measurements. They require post-exposure processing to obtain the dose information. While they are useful for measuring dose distributions in phantoms and in vivo, they are not instantaneous. Option C is incorrect because radiochromic films are indeed used for small field dosimetry, particularly in intensity modulated radiation therapy (IMIT) and stereotactic radiosurgery (SRS), where high spatial resolution is required. Option D is incorrect because silicon diode detectors have energy dependence, meaning their response varies with energy, making them unsuitable for absolute dose calibration. However, they are useful for relative dosimetry due to their high sensitivity. Question 5. Scenario-based question. Palliative radiation therapy. Dr. Nakamura, radiation oncologist, is treating 65-year-old male patient with Th-ruminant and small cell lung cancer (SLCA) that has metastasized to the spine, causing severe pain and reduced mobility. The patient's oncologist has recommended palliative radiation therapy to relieve symptoms. Dr. Nakamura must determine the most appropriate regimen based on the patient's prognosis and treatment goals. Which of the following is the best treatment approach for this patient? At high-dose hypofractionated radiation therapy, G 30 Gi in 5 fractions to maximize tumor control and minimize pain. B. Single fraction of 8 Gi, which has been shown to be effective for pain relief while minimizing the burden of multiple hospital visits. C. Conventional fractionation. G. 60 Gi in 30 fractions to ensure the longest possible tumor control. D. No radiation therapy as systemic therapies. G. Chemotherapy or immunotherapy are sufficient to manage pain in metastatic lung cancer patients. Answer B. A single fraction of 8 Gi, which has been shown to be effective for pain relief while minimizing the burden of multiple hospital visits. Explanation. Option B is correct because a single fraction of 8 Gi has been proven effective for pain relief in bone metastases, with similar outcomes to multiple fraction regimens in terms of pain palliation. Additionally, it minimizes hospital visits, which is particularly important for terminal patients. Option is incorrect because what hypofractionated regimens G. 30 Gi in 5 fractions are sometimes used for metastatic spinal lesions. They may not offer significant advantages in a purely palliative setting. Option C is incorrect because 60 Gi in 30 fractions is an aggressive treatment typically used for curative settings, which is not appropriate for this patient with metastatic disease and limited prognosis. Option D is incorrect because while systemic therapy is an option, radiation therapy is highly effective for localized symptom relief in bone metastases and should not be overlooked. Question 6. Image-guided radiation therapy (IGIT) and motion management. In lung cancer treatment with stereotactic body radiation therapy (SRT), tumor motion due to breathing can lead to dose delivery inaccuracies. Various techniques exist to manage motion, including gating, tracking, and breath hold techniques. Which of the following statements about motion management in lung cancer SRT is most accurate? A. 4CT simulation is essential in LA SRT to account for tumor motion and define the internal target volume (ITV). B. Deep inspiration breath hold (DIB) is primarily used for LA SRT but is not effective for breast or thoracic irradiation. C. Respiratory gating completely eliminates tumor motion during radiation treatment. D. Fiducial marker tracking is an outdated technique and is no longer used in modern SRT treatment planning. Answer A. Forward CT simulation is essential in LA SRT to account for tumor motion and define the internal target volume (ITV). Explanation. Option is correct because forward CT simulation is critical in LA SRT as it allows for the creation of an internal target volume (ITV) that accounts for tumor motion during the breathing cycle. This helps prevent underdosing of the tumor or overdosing of surrounding normal tissues. Option B is incorrect because DIB is widely used in breast cancer treatment, especially for left-sided breast cancers, to minimize heart dose exposure. It is not exclusive to LA SRT. Option C is incorrect because respiratory gating does not completely eliminate tumor motion. It only allows treatment to be delivered during specific phases of the respiratory cycle, reducing, but not eliminating, motion-related errors. Option D is incorrect because fiducial marker tracking is still commonly used, particularly in CyberNIF SRT, where real-time tracking of fiducial markers ensures accurate dose delivery to tumors affected by respiratory motion. Question 7. Radiation protection and ALARA principles. Radiation therapists and medical physicists follow the ALARA as low as reasonably achievable principle to minimize unnecessary radiation exposure. This principle involves implementing engineering, procedural, and behavioral controls to protect both patients and healthcare workers. Which of the following strategies best aligns with the ALARA principle in a radiation oncology department? A. Using high-dose imaging protocols for all patients to ensure the highest quality image guidance. B. Increasing the use of personal protective equipment (PPE), such as lead aprons for all staff even when they are not in the treatment room. C. Using automated patient positioning and IGIT techniques to minimize repeat imaging and unnecessary exposure. D. Eliminating the use of shielding blocks in linear accelerators to reduce radiation exposure to surrounding tissues. Answer. C. Using automated patient positioning and IGIT techniques to minimize repeat imaging and unnecessary exposure. Explanation. Option C is correct because automated patient positioning and IGIT techniques help ensure precise radiation delivery, reducing the need for repeat imaging and thus minimizing unnecessary radiation exposure. This aligns with ALARA principles. Option is incorrect because high-dose imaging increases radiation exposure unnecessarily and should be avoided unless absolutely necessary for clinical accuracy. Option B is incorrect because PPE, such as lead aprons, is not typically required for radiation therapy staff unless they are directly handling radiation sources, such as in brachytherapy. Option D is incorrect because shielding blocks are essential in certain treatments to protect normal tissues from radiation exposure. Eliminating them could increase radiation dose to unintended areas. Question 8. Brachytherapy dose distribution and optimization. Brachytherapy is a highly localized radiation treatment in which radioactive sources are placed directly inside or near the tumor. In high-dose RET HDR, brachytherapy dose optimization is crucial to maximize tumor control while minimizing toxicity to surrounding tissues. Which of the following statements is most accurate regarding HDR brachytherapy dose distribution? A. The dose falls off exponentially with distance from the radioactive source, following the inverse square law. B. Brachytherapy provides a more homogeneous dose distribution compared to external beam radiation therapy. C. The use of multiple dwell positions in HDR brachytherapy has no impact on dose conformity. D. Low dose rate LDR brachytherapy is always superior to HDR brachytherapy for tumor cervical cancer treatment. Answer A. The dose falls off exponentially with distance from the radioactive source, following the inverse square law. Explanation. Option is correct because the dose in brachytherapy rapidly decreases with distance, following the inverse square law, making it ideal for treating tumors while sparing nearby healthy tissue. Option B is incorrect because brachytherapy produces a highly heterogeneous dose distribution with higher doses at the source location and rapid fall-off, unlike EBIT, which aims for more homogeneous dose delivery. Option C is incorrect because multiple dwell positions allow for dose shaping and optimization, improving conformity to the target while sparing normal tissues. Option D is incorrect because both LDR and HDR brachytherapy are effective for cervical cancer. HDR is often preferred due to logistical advantages and equivalent outcomes in many cases. Question 9. Scenario-based question. Total body irradiation TBI for bone marrow transplant. 40-year-old male with acute myeloid leukemia or male is scheduled to undergo bone marrow transplant (BMT). His treatment protocol includes total body irradiation (TBI) as part of the conditioning regimen. Which of the following is the primary goal of EBI in bone marrow transplant patients? A. To directly shrink the tumor before chemotherapy is administered. B. To eliminate residual leukemic cells and suppress the immune system to prevent graft rejection. C. To increase oxygenation in the bone marrow before transplant. D. To stimulate stem cell growth in the recipient's bone marrow before transplantation. Answer B. To eliminate residual leukemic cells and suppress the immune system to prevent graft rejection. Explanation. Option B is correct because TBI serves two main purposes: destroying residual cancer cells to prevent relapse, suppressing the immune system to prevent graft rejection in bone marrow transplantation. Option A is incorrect because while TBI contributes to leukemia control, it is not primarily used for tumor shrinkage. Option C is incorrect because TBI does not increase oxygenation in the bone marrow. Option D is incorrect because TBI does not stimulate stem cell growth. It eliminates existing marrow to allow transplanted cells to engraft. Question 10. Radiation therapy in pediatric patients. Children receiving radiation therapy are a higher risk of long-term side effects, including growth impairment, secondary malignancies, and neurocognitive deficits. Pediatric radiation oncology aims to minimize toxicity while maintaining tumor control. Which of the following approaches is most appropriate to reduce long-term toxicity in pediatric radiation therapy? A. Using proton therapy instead of photon-based therapy whenever feasible. B. Administering whole brain radiation for all pediatric brain tumor cases. C. Increasing total radiation dose to compensate for rapid tumor growth. D. Avoiding radiation therapy entirely in pediatric patients due to toxicity concerns. Answer A. Using proton therapy instead of photon-based therapy whenever feasible. Explanation. Option is correct because proton therapy significantly reduces radiation exposure to surrounding normal tissues, lowering the risk of long-term side effects in children. Option B is incorrect because whole brain radiation is avoided whenever possible in pediatric patients due to neurocognitive decline. Option C is incorrect because high doses do not always improve outcomes and can lead to increased toxicity. Option D is incorrect because radiation therapy is sometimes necessary for tumor control in pediatric cancers such as medulloblastoma and rhabdomyosarcoma. Question 11. Adaptive radiation therapy in head and neck cancer. A 55-year-old male with locally advanced oropharyngeal cancer is undergoing intensity-modulated radiation therapy (IMiT). Due to tumor shrinkage and weight loss during treatment, his radiation oncologist considers adaptive radiation therapy What is the primary advantage of art in this setting? A. Art prevents tumor regrowth by increasing the total radiation dose. B. Art allows treatment adjustments based on anatomical and physiological changes, improving dose accuracy. C. Art eliminates the need for daily image guidance. Again, D. Art is used to extend the overall treatment duration to improve tumor control. Answer B. Art allows treatment adjustments based on anatomical and physiological changes, improving dose accuracy. Explanation. Option B is correct because art adapts the treatment plan to account for anatomical changes, such as tumor shrinkage or weight loss, ensuring the prescribed dose remains accurate. Option is incorrect because art does not necessarily increase the total dose, it adjusts the existing plan. Option C is incorrect because IGIT remains necessary, even with art. Option D is incorrect because prolonging treatment duration can lead to poorer tumor control in some cases. Question 12. Radiation-induced toxicity and management. A 62-year-old woman with locally advanced cervical cancer receives external beam radiation therapy (EBRT) with concurrent chemotherapy. After 4 weeks of treatment, she develops radiation proctitis, experiencing rectal bleeding, diarrhea, and urgency. Which of the following is the best initial management for radiation proctitis? A. Immediate discontinuation of radiation therapy. B. Use of sucralfate enemas and dietary modifications to reduce inflammation. C. Administration of high-dose steroids to suppress the inflammatory response. D. Surgical resection of the affected bowel segment. Answer B. Use of sucralfate enemas and dietary modifications to reduce inflammation. Explanation. Option B is correct because sucralfate enemas and dietary changes, such as a low-fiber diet, can help manage acute radiation proctitis without stopping treatment. Option is incorrect because radiation therapy is continued unless symptoms become severe. Option C is incorrect because high-dose steroids are not typically needed for mild to moderate cases. Option D is incorrect because surgery is reserved for severe, refractory cases with complications like strictures or perforation. Question 13. Stereotactic radiosurgery (SRS) for brain metastases. A 52-year-old female with non-small cell lung cancer (SLCA) presents with 2 brain metastases, each measuring 1.5 centimeters. The treating oncologist is considering stereotactic radiosurgery (SRS) instead of whole-brain radiation. Which of the following is the main advantage of SRS for patients with limited metastases? A. SRS provides superior overall survival comparatively in all cases. But SRS delivers high doses of radiation to the tumor with minimal exposure to surrounding normal brain tissue. C. SRS eliminates the need for systemic therapy as it is curative. D. SRS is only effective for single brain metastases and should not be used for multiple lesions. Answer. SRS delivers high doses of radiation to the tumor with minimal exposure to surrounding normal brain tissue. Explanation. Option B is correct because SRS is a highly precise treatment that delivers high radiation doses to tumors while minimizing exposure to normal brain tissue, reducing neurocognitive toxicity compared to abortion. Is incorrect because overall survival is not always improved, but neurocognitive function better preserved with SRS. Option C is incorrect because SRS does not replace systemic therapy, particularly for patients with active extracranial disease. Option D is incorrect because SRS can be used for multiple metastases, typically 5 lesions, but he may be preferred for extensive disease. Question 14, scenario-based question, image for prostate cancer. 67-year-old man with intermediate-risk prostate cancer is being treated with intensity modulated radiation therapy (IMiT). His physician recommends image-guided radiation therapy (IGIT) to enhance treatment precision. Which of the following is the primary advantage of IGIT in prostate cancer treatment? A. IGIT reduces the number of treatment sessions required. B. IGIT accounts for daily prostate movement, ensuring accurate dose delivery. C. IGIT increases the total radiation dose beyond safe limits to improve tumor control. D. IGIT eliminates the need for androgen deprivation therapy (AT). Answer. B. IGIT accounts for daily prostate movement, ensuring accurate dose delivery. Explanation. Option B is correct because IGIT allows for real-time imaging of the prostate, accounting for daily organ movement due to bladder and rectal filling, ensuring accurate dose delivery. Option is incorrect because IGIT does not reduce the number of fractions but improve precision. Option C is incorrect because IGIT does not increase dose beyond safe limits. Option D is incorrect because AT may still be required depending on risk stratification. Question 15. Bystander effect in radiation biology. In radiation biology, the bystander effect refers to a phenomenon where non-irradiated cells exhibit effects of radiation exposure due to signals from irradiated neighboring cells. Which of the following is the best explanation for the bystander effect? A. Radiation directly damages DNA in non-irradiated cells through secondary ionization. B. Radiation-exposed cells release cytokines and free radicals, affecting adjacent cells. C. Only direct DNA strand breaks in irradiated cells can lead to bystander effects. D. The bystander effect only occurs with high linear energy transfer (LET) radiation. Answer: B. Radiation-exposed cells release cytokines and free radicals, affecting adjacent cells. Explanation: Option B is correct because the bystander effect occurs when irradiated cells release signaling molecules, such as cytokines and free radicals, which induce damage in adjacent non-irradiated cells. Option A is incorrect because bystander effects occur without direct radiation exposure. Option C is incorrect because the bystander effect does not require direct DNA strand breaks in non-irradiated cells. Option D is incorrect because the effect occurs with both high and low LET radiation. Question 16. Treatment planning for lung cancer. Ford CT simulation. 65-year-old male with stade-own non-small cell lung cancer (SLC) is scheduled for radiation therapy. His oncologist orders Ford CT simulation before treatment planning. What is the main advantage of Ford CT simulation in lung cancer treatment? A. It improves the visualization of tumor motion due to respiration. B. It eliminates the need for fiducial markers during treatment. C. It allows for single fraction stereotactic treatment. D. It reduces radiation dose to the tumor while increasing dose to normal tissues. Answer A. It improves the visualization of tumor motion due to respiration. Explanation: Option A is correct because Ford CT captures tumor motion during different phases of respiration, helping improve target delineation and reduce unnecessary dose to normal lung tissue. Option B is incorrect because fiducial markers may still be needed in certain cases. Option C is incorrect because Ford CT is not related to single fraction treatment. Option D is incorrect because Ford CT reduces normal tissue exposure, not increases it. Question 17. Radiation dose constraints for organs at risk ORs. When planning radiation therapy, dose constraints for organs at risk ORs help prevent toxicity. Which of the following is the most appropriate dose constraint for the spinal cord in conventionally fractionated radiation therapy? A. Maxima equals 45 Gi. E. Minus equals 60 Gi. C. Total equals 50 Gi. Answer A. Maximum equals 45 Gi. Explanation: Option is correct because the spinal cord dose is limited equal 45 Gi in conventional fractionation 1.8 2.0 Gi per fraction to prevent radiation myelopathy. Option B is incorrect because mean dose is not the primary constraint for the spinal cord. Option C is incorrect because 70 Gi is too high for spinal cord tolerance. Option D is incorrect because minimum dose is not relevant constraint for ORs. Question 18. Radiation therapy for anal cancer. A 58-year-old female is diagnosed with stegiomental squamous cell carcinoma. She is prescribed chemoradiation therapy using conformal radiation techniques. Which of the following is the primary goal of radiation therapy in anal cancer? A. To achieve local control while preserving anal sphincter function. B. To avoid systemic therapy and prevent distant metastases. C. To serve as an adjuvant treatment after immediate surgical resection. D. To deliver higher doses of radiation to normal rectal tissues to prevent recurrence. Answer A. To achieve local control while preserving anal sphincter function. Explanation: Option is correct because radiation therapy with concurrent chemotherapy is curative for anal cancer while preserving sphincter function, avoiding surgery. Option B is incorrect because chemoradiation does not replace systemic therapy. Option C is incorrect because surgery is reserved for salvage treatment. Option D is incorrect because normal rectal tissues should be spared. Question 19. Intensity modulated radiation therapy (IMT) versus 3 conformal radiation therapy 3DRT in head and neck cancer. A 55-year-old male is diagnosed with locally advanced oropharyngeal squamous cell carcinoma (TNM). The radiation oncologist is deciding between 3 conformal radiation therapy 3DRT, and intensity modulated radiation therapy (IMIT) for definitive treatment. Which of the following is the most significant advantage of IMIT over 3DRT for head and neck cancer? A. IMIT allows for shorter treatment duration compared to 3DRT. B. IMIT reduces radiation dose to nearby organs at risk ORs, such as the salivary glands and spinal cord. C. IMIT completely eliminates the risk of radiation-induced mucositis. D. IMIT increases local control rates in all head and neck cancers. Answer: B. IMIT reduces radiation dose to nearby organs at risk ORs, such as the salivary glands and spinal cord. Explanation: Option B is correct because IMIT allows for highly conformal dose delivery, reducing radiation exposure to critical structures like the salivary glands, reducing xerostomia and the spinal cord. Option is incorrect because IMIT does not shorten treatment duration. In fact, it often requires longer planning and delivery times. Option C is incorrect because IMIT does not eliminate mucositis, though it may reduce severity. Option D is incorrect because while IMIT improves local control in some cases, it is not universally superior to 3DRT in terms of tumor control. Question 20. Total body irradiation (TBI) for bone marrow transplantation. A 42-year-old male with acute myeloid leukemia (AML) is scheduled to undergo allogeneic bone marrow transplantation. His treatment plan includes total body irradiation (TBI) as part of the conditioning regimen. What is the primary purpose of TBI in this setting? A. To sterilize the bone marrow and prevent future leukemia relapse. B. To destroy residual cancer cells and suppress the immune system for engraftment. C. To directly cure leukemia by eradicating all leukemic cells. D. To replace chemotherapy as the sole treatment for AML. Answer: B. To destroy residual cancer cells and suppress the immune system for engraftment. Explanation: Option B is correct because TBI is used in bone marrow transplantation to eliminate residual leukemic cells and suppress the immune system, preventing graft rejection and graft versus host disease (GvHD). Option is incorrect because while TBI does sterilize bone marrow, its main role is to prepare for donor cell engraftment. Option C is incorrect because TBI alone does not cure AML. It is part of a multimodal approach. Option D is incorrect because chemotherapy Usulfan cyclophosphamide is usually combined with TB. Question 21. Role of proton therapy in pediatric brain tumors. A 7-year-old girl with medulloblastoma is being considered for proton beam therapy (PBT) instead of conventional photon radiation therapy. What is the main advantage of proton therapy in pediatric brain tumors? A. Proton therapy eliminates the need for chemotherapy. B. Proton therapy reduces radiation dose to normal brain tissue, lowering the risk of neurocognitive deficits. C. Proton therapy is significantly faster to deliver than photon therapy. D. Proton therapy increases the total radiation dose delivered to the tumor. Answer: B. Proton therapy reduces radiation dose to normal brain tissue, lowering the risk of neurocognitive deficits. Explanation: Option B is correct because proton therapy has a Bragg peak, allowing high-dose tumor targeting while sparing normal tissue, reducing the risk of long-term neurocognitive deficits. Option is incorrect because chemotherapy is still required in medulloblastoma treatment. Option C is incorrect because proton therapy often requires longer treatment planning. Option D is incorrect because the radiation dose is not necessarily increased. The goal is precision and reduced toxicity. Question 22. Spinal cord compression from metastatic cancer. A 62-year-old woman with breast cancer and bone metastasis presents with progressive back pain, weakness in her lower extremities, and urinary retention. MRI reveals spinal cord compression at TT. What is the most appropriate initial management? A. Immediate surgery followed by radiation therapy. B. High-dose corticosteroids followed by urgent radiation therapy. C. Observation and pain management. D. Chemotherapy as the primary treatment. Answer: B. High-dose corticosteroids followed by urgent radiation therapy. Explanation: Option B is correct because high-dose corticosteroids e.g. dexamethasone 1020 and Geman would be started immediately to reduce spinal cord edema, followed by urgent radiation therapy to relieve pressure on the spinal cord. Option is incorrect because surgery is considered for radio-resistant tumors e.g. sarcomas, renal cell carcinoma, or if radiation therapy fails. Option C is incorrect because observation is inappropriate in acute spinal cord compression. Option D is incorrect because chemotherapy alone is insufficient for acute spinal cord compression. Question 23. Radiation-induced secondary malignancies. A 45-year-old male received radiation therapy for Hodgkin's lymphoma at age 20. He is now diagnosed with soft tissue sarcoma in the radiation field. Which of the following is the most likely cause of this secondary malignancy? A. Genetic predisposition alone. B. Chemotherapy-related toxicity. C. Ionizing radiation exposure leading to DNA damage. D. Immunosuppression from past cancer treatment. Answer: C. Ionizing radiation exposure leading to DNA damage. Explanation: Option C is correct because radiation-induced DNA damage can cause secondary malignancies, particularly sarcomas, breast cancer, and leukemia. Option A is incorrect because radiation exposure is the primary cause, though genetic predisposition may increase risk. Option B is incorrect because chemotherapy, alkylating agents, can cause leukemia, but solid tumors are more linked to radiation. Option D is incorrect because immunosuppression is not the main mechanism for secondary solid tumors. Question 24. Whole brain radiation versus SRS in brain metastasis. A 60-year-old man with lung cancer and 4 brain metastases, each 2 centimeters, is being considered for radiation therapy. Which approach is preferred in this case? A. Whole brain radiation alone. B. Stereotactic radiosurgery SRS alone. C. Surgery followed by D. Observation without treatment. Answer: B. Stereotactic radiosurgery SRS alone. Explanation: Option B is correct because SRS is preferred for patients with a cause 5 brain metastasis to preserve cognitive function while achieving local tumor control. Option is incorrect because B can cause neurocognitive decline. Option C is incorrect because surgery is reserved for solitary or symptomatic lesions. Option D is incorrect because untreated brain metastases lead to poor outcomes. Question 25. Stereotactic body radiation therapy SRT in early-stage lung cancer. An 80-year-old male with severe COPT is diagnosed with stage I non-small cell lung cancer (SLIM). He is not a surgical candidate due to poor pulmonary reserve. What is the preferred treatment approach in this case? A. Conventional fractionated radiation therapy. B. Stereotactic body radiation therapy SRT. C. Chemotherapy alone. D. Observation with follow-up CT scans. Answer: B. Stereotactic body radiation therapy SRT. Explanation: Option B is correct because SRT is the standard of care for medically inoperable early-stage SLC due to its high local control rate, 90%, and minimal toxicity. Option A is incorrect because conventional radiation therapy requires 6 weeks of treatment, whereas ERT delivers a high dose in 3-5 fractions, reducing lung toxicity. Option C is incorrect because chemotherapy is not curative for stage ISLC. Option D is incorrect because observation is not appropriate for an early-stage curable lung cancer. Question 26. Radiation dose constraints for the spinal cord. A 58-year-old female with spinal metastasis is planned for palliative radiation therapy. What is the maximum recommended radiation dose to the spinal cord to minimize the risk of radiation myelopathy? A. 10 Gi, a single fraction. B. 20 Gi, 5 fractions. C. 45 Gi, 25 fractions. D. 60 Gi, 30 fractions. Answer: C. 45 Gi, 25 fractions. Explanation: Option C is correct because the spinal cord radiation tolerance is 45 Gi in conventional fractionation, 1.82 Gi fraction. Option is incorrect because 10 Gi, 1 fraction, is below the tolerance dose, but higher doses, e.g. 16 Gi, 1 fraction, increase the risk of myelopathy. Option B is incorrect because 20 Gi in 5 fractions is safe for palliative cases, but higher doses require careful planning. Option D is incorrect because 60 Gi exceeds spinal cord tolerance, increasing the risk of radiation myelopathy. Question 27. Brachytherapy in cervical cancer. A 45-year-old woman with FIGO stage IB cervical cancer undergoes external beam radiation therapy with concurrent chemotherapy. What is the next step in her treatment? A. Adjuvant hysterectomy. B. Pelvic lymph node dissection. C. Intracavitary brachytherapy. D. Additional chemotherapy cycles. Answer: C. Intracavitary brachytherapy. Explanation: Option C is correct because intracavitary brachytherapy is essential after EBIT for locally advanced cervical cancer, improving local control and survival. Option is incorrect because hysterectomy is not routinely performed after definitive chemoradiation. Option B is incorrect because lymph node dissection is not necessary after radiation. Option D is incorrect because chemotherapy alone is insufficient for local tumor control. Question 28. Radiation therapy in glioblastoma GB. A 62-year-old male undergoes surgical resection of a glioblastoma GBM at grade 4. The radiation oncologist recommends adjuvant radiation therapy with concurrent temozolomide. What is the standard radiation dose and fractionation for glioblastoma? A. 30 Gi in 10 fractions. B. 40 Gi in 15 fractions. C. 60 Gi in 30 fractions. D. 75 Gi in 35 fractions. Answer C. 60 Gi in 30 fractions. Explanation. Option C is correct because the standard dose for GBM is 60 Gi in 30 fractions, 2 Gi fraction with concurrent temozolomide. Option A and B are incorrect because 3040 Gi are palliative doses used for elderly or poor performance status patients. Option D is incorrect because 75 Gi increases toxicity without improving survival. Question 29. Prostate cancer and androgen deprivation therapy with radiation. A 68-year-old male with intermediate risk prostate cancer, Gleason 7 cytangioma E, is scheduled for definitive radiation therapy. What is the role of androgen deprivation therapy in this setting? A. AT should be given for at least 2-3 years. B. AT is not needed in intermediate risk prostate cancer. C. AT improves outcomes and should be given for 4-6 months. D. AT is used only for SSAs to prevent AG. Answer C. AT improves outcomes and should be given for 4-6 months. Explanation. Option C is correct because 4-6 months of AT with radiation improves disease-free survival in intermediate risk prostate cancer. Option O is incorrect because long-term AT, 2-3 years, is used for high-risk prostate cancer. Option B is incorrect because AT is beneficial in intermediate risk cases. Option D is incorrect because AT is used based on risk group, not SSA alone. Question 30. Acute versus late radiation toxicity in pelvic radiation. A 55-year-old woman with endometrial cancer receives pelvic radiation therapy. She develops diarrhea and urinary urgency during treatment. Which of the following best describes the expected timeline of radiation toxicity? A. Acute toxicity occurs within weeks. Late toxicity occurs months to years later. B. Acute toxicity occurs after 6 months. Late toxicity occurs within 3 months. C. Acute toxicity only occurs in high-dose treatments. D. Late toxicity is reversible and resolves within 1 month. Answer A. Acute toxicity occurs within weeks. Late toxicity occurs months to years later. Explanation. Option is correct because acute radiation toxicity G. Diarrhea, cystitis, skin reactions occurs during or shortly after radiation weeks, while late toxicity G. Fibrosis, bowel strictures, secondary malignancies appears months to years later. Option B is incorrect because acute toxicity does not appear after 6 months. Option C is incorrect because acute toxicity can occur in any dose level, not just high-dose treatments. Option D is incorrect because late toxicity is often irreversible.